Okay, sir. Proceed,
surgical
sir.
approach to the hip, especially for the total hip replacement. And other part I will do it as a second phase for other pediatric and other surgeries. So what is ideal approach for a hip replacement? You should have a wide exposure so the surgeon is able to see everything possible what he is doing. Secondly, should be useful for a wide array of deformities. It should not be only a small deformity. We should be able to use the cross deformities also. Efficient bloodless surgery and minimal tissue trauma. So surgeon has to be very, very careful of minimal trauma so that the pain is less, the amount of injury will become less, and then that becomes a better surgery. And you should have early post-op recovery for these patients and with best possible minimal complication. I know as a surgeon we will have some complication, there is no question, but you should not have maximum complication, absolutely minimal so that should be your ideal goal for any approach to the hip. So the approach classification can be anterior, can be anterolateral, transtrochanteric, which was popularized by John Charnley, extended trochanteric, posterolateral approach, and minimal invasive approach. That is the way we will move. What is meant by anterior approach? Now, if you look at cursor, okay, that is the anterior Smith-Peterson approach. This was between the tensor fascia lata and rectus femoris, and we enter the joint capsule. Are you able to see Srikunj?
Yes, sir.
Okay, that is the Smith-Peterson approach, that was well described way back, long back, and that's your anterior approach. The second approach is Watson-John approach. Watson-John approach was in between the tensor fascia lata and gluteus medius. That used to be between the that is known as Watson-John approach. The Harding approach, the gluteus medius was split. The minimus was kept intact. This was split either 1/3, posterior 1/3 or anterior 2/3, and the different varieties which I will tell you. But you cut the gluteus medius, keeping the tendon intact, and then you enter and keep the minimus intact, and you enter here. And that was a Harding approach. And the posterior approach was splitting the gluteus maximus and not the medius. Medius is and minimus, everything is kept intact. So again, I am very crystal clear to all of you. This, if you draw this figure, probably this examiner or whatever the people who are going to read your paper, they will know this, because this is an extremely important figure. Now again, repeating Smith-Peterson. Smith-Peterson is between the rectus and the tensor fascia. This is no muscle is cut. It is internervous plane. Okay, and Watson-John approach was between the tensor fascia lata and the gluteus medius. So the medius is behind, and the tensor is in the front. So you reach the capsule there. And Harding approach, you cut actually part of the gluteus medius, and that's why a lot of people feel that we will come to that why disadvantage of this Harding approach. And posterior approach, we split the gluteus maximus and we enter the from behind. So that is the way roughly approaches. So by history, actually by 1817, Carl Hutter this is the man who described actually anterior approach. But people didn't realize at that time. And after 100 years, Smith-Peterson from US surgeon, because he was English-speaking gentleman, he popularized to the English-speaking world. So Smith-Peterson approach, I told you, between the tensor fascia lata and the gluteus medius was popularized by Smith-Peterson. Then in 80s, it was repopularized by Jude brothers from France and Kegi. These were three surgeons. They repopularized because in between he lost completely. So the Jude brother, they were doing with this Smith-Peterson approach. They were operating, and actually my boss also had an opportunity to see Jude brother, and he also, my chief, did some of the Smith-Peterson approach with a Jude implant. That was acrylic implant. Recently, this approach was renewed, more importantly, biochemically, and so many other biomechanically and gait analysis and so many things. This approach is renewed with the work of Joel Mata, Richard Berger, Cannon, and Schreiber. These are the four people who recently, in last about 7 or 8 years, has completely changed the approach, completely changed the whole thing in anterior approach. So this is just to know all of you. This is Smith Peterson from US. This is Jude Brothers. This is the he was a senior man, that is Robert, and Jane was his a younger brother. Jane was a younger brother, and this is Kagi, and this is Joel Mata. Joel Mata, you must be knowing, this is the man who has a lot of work on acetabular fracture, the largest work in acetabular fracture, and plus he has renewed the whole anterior approach things different way. So Joel Mata is one of the dynamic surgeon today in US. So I had told you there's a Hooter, Smith Peterson, so Jude acrylic. This is all done. This anterior approach is done in supine position. And when it started working at the time, about 8-10 years back, it required a special operating table. And there was a Jude table. This was modified by many people. But the anterior approach requires special table, and it's a very expensive table. But last 2 to 3 years, the surgeons have become bold. And now there are many surgeons who do not use this table. So this can be done on supine ordinary table, but requires image intensifier so that it becomes a radiolucent table, because you need image inside. So my technique is incision, interval, capsular incision, which I'll tell you all the details. How the incision is, how to go inside, how to inside the capsule, and how to go inside with anterior approach. So if you look at this very important figure, there's a dead lateral approach. This is usually done by Hardings, and that's your anterior approach, and that's a posterior approach. This is the plane. Now, if you look at the very carefully, this is a very important plane, which I already told. This is your rectus femoris, which remains in the front. The tensor fascia remains behind, and you enter the capsule. So this is in between, exactly in between the two muscles. We don't cut any muscle. We don't cut any nerve, and only few vessels are ligated, which I'll tell you. So this is absolutely fairly bloodless field to enter inside. So again, I'm repeating. This is the plane, very important plane. The rectus remains in the front, the tensor fascia remains in behind, and you enter right into the capsule. So your neurovascular and everything remains far away from this approach. So this is a supine position. Both legs are draped in this patient. Reason is they want to palpate. They want to palpate the malleoli to know the limb length. With all preparation, we will not be able to. So the both legs are usually draped. Some of the people are keeping a small sandbag under the sacroiliac joint to lift it, but many people do not. And your incision is the anterior iliac spine, anterior superior spine, 2 centimeter down, 2 centimeter posterior, and that is a straight incision, not a curved incision. Usually about 8 to 10 centimeter is the usual incision. Again, I'm repeating: anterior superior spine, 2 centimeter down, 2 centimeter posterior, straight lateral, dead lateral. Many people try and palpate the TFL and just hold the TFL and just get a center in the center of the TFL. That is, a lot of people do that. So that's a trick of this incision. If you go wrong in this incision, probably it's very, very difficult to go in the front. So incision is a very important landmark in this anterior approach. So the most important structure which we have to protect is this is lateral cutaneous nerve, which goes from the anterior superior iliac spine down into here, and it gives the branches to the gluteal branch and femoral branch at this level. So with this, lot of retraction takes place under the rectus, and that's why there are a lot of people develop femoral neurocutaneous symptoms. They don't get palsy or don't, but this is a sensory branch. So they develop something like meralgia paresthetica, which is very, very common. It takes about 6 to 8 weeks before they recover. And very important you've got to tell the patient. and more fattier patient, more is the problem. So you must tell the patient that this will recur, but it is a very annoying complication, annoying symptom for a patient, because they get a sleepless night with a lateral cutaneous nerve neuralgia. So again here, if you look at the very carefully, that's the tensor fascia coming behind and the sartorius and rectus in the front. And you are directly dead into the capsule of the hip joint. So look at this very carefully. Two retractors coming in the front are now reflecting rectus and sartorius, and this retractor is retracting tensor fascia. And this is the capsule. And very important structure here is the one of the branch of the artery and vein, which is here. You have to actually, this is a lateral circumflex artery, and along with that there is a vein, along with that there is some of the nervous tissue. And very important sign to identify, there's a pad of fat around these vessels, and we'll be very, very careful. Once you see the pad of fat that the vessels and neurovascular structure is there, that is one of the important, that God has given a greatest protection. Even if you look at the very other areas also neurovascular, when you do a posterior approach with sciatic nerve, it is all with a full of fat there. So that's a very classical sign also. So this is a going right transverse here. And very important that you got to, most surgeons will ligate. Sometimes some of the surgeons are bold, they do a cauterization. If it slips, there's a large hematoma and it's very difficult. You can't stop the bleeding because it gets retracted. So as a good surgeon, better to transfix or ligate this vessel properly, both the side very well, and then you cut it. That's the best way. Then we are retracting here. Now, here we cut the capsule thoroughly, because don't capsule cut short, because we need also to suture this back. So we take a tag suture of the capsule. We cut the capsule right from anterior to posterior as much as possible, as much as in the front and as much as behind. This retractor actually goes on the anterior column of the acetabulum. This retractor is protecting that whatever the vessel you have cut, that is protecting again, not allowing to go again their knife again. And this will be the whole of the capsule stripped with a periosteum. Sometimes you have a reflected rectus that has to be stripped completely, very well stripped completely. Otherwise, you are going to be in difficult problem. And once you cut this, you take a tag suture with ethylon or whatever material, ethibond, whatever material you want. Here, we can't dislocate the hip. This is one important, remember, all of you have to remember. Any manure, it's just not possible to dislocate the hip, because this is a very, very small approach. So you need to cut the neck and take the napkin cut or a sandwich cut. So we cut the neck, we take another 1 centimeter of cut, take out the big wedge, and then put a corkscrew from this side or this side, one of the side, and then deliver the neck. So important information, proper capsular cut. Second, take the napkin cut or what is called as a sandwich cut of the neck, at least 1 to 1.5 centimeter, and then extract with a corkscrew screw. You cannot dislocate the hip. Then we got to use a special reamers. Ordinary reamers cannot work, because if you are going to be an ordinary reamer, the cup is going to be more vertical, because you need to ream the angle reamer, because here is the tissue which may not, look at that, which may not allow you to ream into 40 degrees and 10 to 20 degrees of anteversion or according to the TAL. So it is just not possible with an ordinary straight reamer. Another important message, you need offset handle, offset reamers, offset cup holder, then only you can align this cup exactly. So putting a trial, get the image intensifier inside. That is another important. And you have to see alignment, anteversion. You can see the eye is open here. Number 2, it is near the teardrop, so it is anatomical. medial wall is intact. You are not broken the medial wall. The cup is sitting very much. So bottoming of the cup has taken beautifully bottoming. So this, and it is covered beautifully, almost 97, 98%, a little bit outside, which happens normally with uncemented cups. So once your trial is done, then you take a real implant and put it and put a poly. So that is the acetabulum. So important is proper retraction there, going on the anterior column, going into the posterior and exposing 360 degrees of acetabulum before you start reamer. This cannot be a blind procedure. Now, most important is the femur. Release in order. Highest complication in anterior approach has been reported from 0 to 20% is the femoral fracture, calcar fracture, trochanter fracture, perforation and whatnot. This is the most tricky part of the operation, where that's why the surgeons are failing to get the femur out of the wound, so that you can see it properly and then you will be able to ream. Now, how do you do this? First, release the superior capsule, complete superior capsule. Release the superior capsule. That is the first step. Then second, release this area, this corner area. That is known as a medial femoral neck. Release the capsule from the medial femoral neck. Then you take this is called double prong retractor. This is a double prong, very sharp double prong. Put that retractor there and lift the femur. If it comes out from the wound, you don't need to do anything. Now suppose you are not able to deliver the neck outside the wound, partly. The third structure you release is vertical episiotomy of the posterior capsule. This is usually the capsule is the posterior capsule is here. So we do episiotomy from there till the piriformis fossa, till the piriformis. So next step, first step, capsule release superior, followed by medial capsule, followed by vertical episiotomy of the posterior capsule till you see the piriformis tendon. The piriformis tendon, you know, there is a fossa. It is attached to the trochanter on the medial side. Don't release at that level. Don't release the piriformis tendon. Suppose now still the hip is tight, the femur is not coming up. The third structure, you need to release piriformis tendon. Release. You will be able to see very carefully the tendon, very wide glistening structure. You cannot miss that. Now still you are not able to get it. So the last structure you realize is you try to release the little bit of tendon, and if still not coming, then you need something else to do it. But that means something is going wrong. At any cost, do not release obturator externus tendon, which is a dynamic stabilizer of the hip. So don't release obturator externus. So I'm repeating again. First is superior capsule, followed by capsule on the medial femoral neck. Third is a vertical episiotomy of the posterior capsule till piriformis, and last is the piriformis tendon. That's it. So that is the sequence of release of bringing the femur up out of the wound, and then you broach from the most lateral side of the canal, lateral side of the femoral neck, that is in the trochanteric fossa, that is a piriformis fossa, so that you are able to enter into the center, and you might you require lateralization. Is it clear to all of you? Subin bhai?
Yes, sir. Absolutely clear.
Yes, sir.
Okay.
Yes.
So after putting the femur trial, then do a trial reduction. Don't take the implant. Acetabulum, you are taken it off. But now don't take the implant. Trial and see the amount of external rotation has been achieved. Almost about 60 degrees. The hip does not dislocate anteriorly. So this is the most common thing which happens, anterior dislocation with external rotation with this approach. Now this is a flexion, almost about 80 to 90 degrees. Check the limb length, so you know the things are. Get image inside if you required, and then see the limb length, also interteardrop line. Then take the real implant, take whatever the femoral head, metal, whatever is required. Then put it inside, and then check final check. Final check is done, that the right in the center, you have maintained the offset, you have maintained so many things, teardrop, everything is there. So these are the things which you know it. But still, I'll repeat. Acetabulum right of the teardrop, bottom has taken place, almost 100% is contained, and there is a Kawa angle. Kawa angle is the line drawn from the acetabulum from superior, inferior. This is the line of this, and this is the line of the head, femoral head. Both should be parallel to each other. That is known as a Kawa angle. It's just normal rotation. And after you are this, you look at this. These are the tag for the capsule, which I told you. This is the suture. We have to keep them. Look at this. This is a TFL, and that's a part, other part of the TFL which we have split. That's the only split which has taken place here. And now you repair the capsule, anterior capsule, which you have taken the straight suture, and then you are straightway you are there. So that is the dissection. You should have a fantastic dissection without having any damage to the TFL. That's the way anterior approach is done. What is the advantage? No muscle disturbance, rapid recovery, decreased rate of dislocation. That's why now 60% of the US surgeons are trained for anterior approach. Unfortunately, in our country, there are only 3 or 4 surgeons, I think, on the counting on the fingers only, are doing anterior approach, because our hips are different, training is different, which will come to it. No hip dislocation precaution. So when you operate this patient, they are going either same day evening back home or next day morning they are going. No precautions. They can lie down whatever they want. They can walk with a walker. They can get up and down to the stairs. No precautions. No pillow in between. No pillow in between. They can do internal, external rotation, whatever they want. That is the one of the important thing of these patients are. Image intensifier can use the accuracy of the component. You have seen how the femur is in the neutral, how the acetabulum, because we are using image. In other approaches, we are not using image because very difficult to get the image and get the implants properly seen. And limb length accuracy, because you are doing 2 things. One, you are seeing on the image problem. Second, you are seeing both the legs are draped, so that you can both the malleoli can be palpated well. You can bring them together and see. Disadvantage: very steep learning curve, highest rate of complications have been reported. That intra and femoral fracture, I told you, 0 to 5 to 3%. Very early reports were reported, and now, if there is a problem has occurred, suppose fracture or something, you can't extend. It becomes very, very difficult. So extension becomes difficult. Now it has been reported that it is possible for a surgeon with a high caliber, it is possible to extend, but for an ordinary surgeon, it is not possible, because he will have to close the wound and get back to the posterior approach and do the things. Posterior acetabular deficiency cannot be managed with this approach. This is the special table required, Jude table, and many surgeons are now operating on the ordinary table, but the image facility, radiolucent tables must be available. So that is the way we do this now. So what is the this one pros and cons between the anterior and anterolateral approach? If you look at the anterior approach, this is anatomical, special traction table, special cases. Preserves posterior structures. That's why the rate of dislocations are negligible. Only problem is the lateral cutaneous nerve, which I told you it is at the highest risk, and that's why you have to actually literally take a consent of these patients. Preserve abductor muscle, because you are intermuscular pain. We are not touching abductor at all. You are far away. Only a long learning curve. Low dislocation rate, quick recovery without restriction, no precautions. Easy to lengthen as a very senior, for a senior surgeon, not for a normal surgeons. Anterolateral approach, that is a Harding's approach and modified Harding. So many approaches are there, which we will discuss when we discuss the lateral approach. It's a usually very easy approach. Only problem, you are disturbing the abductor, because you are cutting the abductor either 1/3 or half. Some of them are 2/3. Depends on what you are trained. And that's why these people have almost 3 to 6 months abductor limp. Then short learning curve, very quick to learn actually anterolateral approach, very quick, very quick. And only other problem is superior gluteal nerve. If you go 5 centimeter above the tip of the trochanter, you will damage superior gluteal nerve and they can have a permanent abductor palsy, and then they will start dislocating because of the abductor palsy. You have a good wide view, low dislocation. Again, it is a low dislocation anterolateral approach because you are keeping the anterior capsule intact. Another risk of is the heterotopic ossification has been reported much more compared to posterior approach, compared to anterior approach, because you are cutting the muscle belly. That is the reason most of the people feel that the heterotopic ossification is on the higher side. What about the comparison between the posterior and anterior approach? Risk of femoral fracture in the posterior approach is low. Anterior approach is much more. I told you from 0 to 5. Lateral cutaneous nerve less than 1%. It is much more lateral cutaneous nerve. That is, again, I am repeating. If you write in an exam that lateral cutaneous nerve is a problem, examiner will give additional mark. Risk of dislocation is 3 to 4%. It is less than 1%. That's why most US surgeons and most now the French and as well as the German surgeons have switched on to the anterior approach. Probably one or other day, this will be a common approach in our country. The younger surgeon will have to take it because even though there's a learning curve, I think people have to try and get this anterior approach popularized. Functional outcome. Lower in first 3 months, that's why I told you, because you are cutting the abductor, they have a little pain, abductor deficiency. But the similar, after a couple of months, the approach, this becomes the same. Higher up to 3 months, and after 3 months, it is the same. Mean hospital stay usually 4 days is 2.9, depends. Discharge home, most of the patients go to the, almost 16% patients go to rehab centers, but here only 3% go to rehab center. Most of the people will go home because there is no precaution. Soft tissue damage, lot of work went on because a lot of people felt that so much of retraction is taking place, so much of maramari occurring during the surgery because exposure becomes very, very difficult. So a lot of people felt that we are doing a lot of soft tissue damage. So a lot of cadaveric studies, the posterior approach significant damage to piriformis, rotator and gluteus minimus. That is a posterior approach. The anterior approach has significant damage to tensor fascia because you require a lot of release. You right up to go to the iliac crest to release the tensor fascia lata before you retract them behind, and rectus femoris has to be released quite a lot. And 50% cases piriformis is distinct. I told you, when you want a femur preparation, 50% of the patients we need to cut the piriformis. I told you after episiotomy, you need to cut the piriformis, but obturator externus we keep it intact because it's a great stabilizer. So this is the work went on. So looking at the biochemical markers for tissue damage, a lot of work again went on. Creatine kinase, CRP, interleukin 6, pain score, no major difference with the anterior and posterior approach has been. Some surgeons have shown better results and they are very specific surgeons. They are people who are operating more than 200 cases per year. They have shown the creatine kinase CRP are on the lower side, but an average surgeon has got almost same biomarkers of tissue damage. So keeping in mind that tissue damage may not be you have to keep in mind. It happens. Gait analysis. Slight advantage with anterior approach because the gait is closer to normal pattern in early phase. But after I told you about 12 months or so, both the gaits are almost same. What approach you use, whether you use posterior, whether it's anterolateral, whether you use the anterior approach, they all they're all right after about 12 months time. But definitely greatest advantage. That's why the people are able to go and join the job before 6 weeks. Caution. There is I had told you, transverse and descending branch of lateral circumflex artery along the accompanying motor branch to vastus lateralis and vastus medialis may have denervated, and that's why there is a big caution for anterior approach. If you try and extend incision down, so this is the vessel which I just shown you, transverse vessel. That is important to ligate it properly and don't avoid the damage to the nerve. That is important. This is important caution for anterior approach. Obesity, skin necrosis, very high incidence with this approach because I told you retraction. That's the biggest problem because you need a Hercules assistant on and at least in the front side or not on the your side. You require a lot of retraction to take place, and that's the reason a lot of people fail that that is the reason. That's why the most of the people are using subcutaneous closure rather than any staples or anything. So that's about the anterior approach. If any there are questions, please let right now we clear it. So Srigunj, if anybody wants to ask anything.
Yes, anybody wants to ask question regarding anterior approach, go ahead. Anybody? Okay, sir, you can proceed, sir.
Feel new to them and new to me also. We can go to anterolateral.
Yes, sir. Proceed, sir. Proceed.
Okay. Okay. This was originally described anterolateral. I told you between the this one was the between the tensor and the in the front gluteus. So originally described was Watson-John without damaging the abductor. No damage to the abductor. So it was between the tensor fasciae lata, rectus in the front, sartorius in the front, and the abductor is behind. That is the way Watson-John went inside. The posterior soft tissue is preserved, less chance of dislocation. That is the way the Watson-John described the approach. The whole thing was kept in, and the whole abductor, if you look at this, very classical, whole abductor was kept intact. And you are in the front here. And that's the behind. That's the way it went on to the Watson-John approach. But this was modified by many people, and two people are claiming highest claim is the Bauer approach. This is from Germany, which I've seen actually a lot of people operating when we went to Germany. It's a very good approach. And second is a Harding approach. Harding approach was 1982. Harding, anybody knows who was Harding?
Yes, anybody?
My dear. Anyway, Harding was from Wrightington, UK, and he was actually the Chanley was in other unit and Harding was in other unit. Both were separately operating. So the Chanley was doing a transtrochanteric approach and Harding was doing a the anterolateral approach, which this one there. And Harding actually learned this approach from Osborne, who was from Liverpool actually, and he modified slightly. And the claim now is the Harding approach all across the world. He was a very gentleman. He was at Wrightington Institute, Wrightington. Unfortunately, I had no chance to see him, but he himself had a fracture dislocation of the hip after having his some major accident. That was the Harding from UK. So all of us, you should know that he modified from the Osborne approach, and we will discuss how the Harding approach is. Posterior tendon of gluteus maximus is left attached to the trochanter tubercle, and anterior to the piriformis, all structures are released, keeping gluteus minimus intact. So this is why I told you, this is the Harding modification of McParnell and Osborne approach. Osborne was actually professor of Liverpool University. A lot of people, Indian people, worked under Osborne. So if you look at this is a gluteus maximus. All of you can see, there's a tendon of the gluteus medius here. That's the vastus lateralis here. And you start, a lot of people keep only tendinous portion behind, and most of the muscle, take it in the front. But a lot of people modified this and keeping the tendon and some part of the muscle much more. Posterior 1/3 has to be kept and anterior 2/3 can be taken in the front. That's the way modification has taken place from the Harding approach. And why this approach was developed? On embryologically, vastus lateralis and abductor are a single myotome. So that is the reason Harding did a work on this. And he said, if you do this, cutting the even abductor and vastus, part of the vastus, they will not have any neurological problem, or they will not have any major problem of nerve injury. So this is a single sheet, single myotome, and that's why he popularized this operation. So you have to cut vastus lateralis, take this posterior third here, and take the whole thing in the front here. Keep, this is the gluteus minimus, keep the gluteus minimus intact. You don't have to release, and you are right in the front. If you have a difficulty, you can release a part of the gluteus minimus, so you suture it back. But release the gluteus minimus at the level of the junction of at the level of the bone where there is some part of the tendon. The gluteus does not have a actually good tendon. So it is a musculotendinous junction. You cut it there, and you will be able to go in the front. So keep your dissection right on the bone. There are a lot of modification. There is one modification known as a Liverpool modification, which I had opportunity to work 1 year in Liverpool, which I did. I learned there. Instead of using a cautery here, you take the curved osteotome and use the part of the thin sliver of the trochanter along with this muscle, and then you suture back. So that small trochanteric piece will be attached this portion here, in this portion, with this slap, with this in the end front, and then you get into the front. So you can do that. That is one modification, Liverpool modification, but trochanteric sliver, and you suture with a very, very strong suture, ethibond suture. There are 2 or 3 sutures coming from here, and they will get it. And you got to close the vastus lateralis also. So that's the way the Harding approach is. So again, the same thing which here is the skin inches slightly posterior incision. That is your TFL. That's your hip abductor. This is a tendon of the gluteus medius, major tendon. Either keep a posterior third or anterior 1/3 here. That's the vastus lateralis cut. You are right in the front there, deep dissection. So important. From here to here, 5 centimeter, you should not go. Why, Srikunj?
Sir, ask it again, sir.
You don't cut the abductor here more than 5 centimeters from the tip of the trochanter.
Because of superior gluteal nerve, sir.
Yes. So a lot of people take a stay suture here to remind yourself, remind as a surgeon, so that you don't go above. You
Yes,
take
sir.
you take the marker, the scale, and at the 5 to 6 centimeter, you take one stay suture there. So a lot of people do that. So that is one important information. Okay, so this is the various modification I told you. Trochanteric slide modification, Frank Dyke and Morley, they are all various varieties of them, but these are all nothing but the Harding approach modification, keeping half, keeping 1/3, all that thing, whether you take a large piece of trochanter or whether you take a sliver and then either fix with a suture, or you can put the 2 screws if required. Freeze meter, because the lecture is going on, but I can't eat. Thank you. Okay, so abductor weakness, loss of fixation of abductor from the trochanter. So whatever you try and fix, sometimes you may not be, so it will get, sutures will give way. Okay, so you can't have a no resistive exercise for 6 weeks, continue use a cane until your lurch goes. And I told you this is the superior gluteal nerve, and that's your 5 to 6 centimeter. That is the reason. And second important thing, which I again told you in the before during the anterior approach, that heterotopic ossification is much common because you are cutting the abductor, part of the abductor muscle. That is the reason the ossification is much more than the posterior approach than the anterior approach. Well, this important information you have to put on your paper. So this is where why we use this approach, because the rate of dislocation is very low. So you should use in alcoholic patients, uncooperative patients, neuromuscular like Parkinson's, hemiplegics, elderly patients who don't have the good ground phenomena. Cognitive disorders are very high in elderly patients. They don't have the feedback mechanisms. Severe FFD, then you release the anterior capsule with this patient, with a posterior approach, it will be very difficult to release the anterior capsule. So when you have got a severe flexion deformity, you can use this approach because you are going to release the whole of the anterior capsule from the front, which will reduce. Even if you want to release some other structure, you can do this. Bilateral simultaneous can be done. It's not necessary that. Ankylosing is not necessary. Obese patient, you can do it because the rate of dislocation will reduce. A posterior approach with the obese patient, most obese patient has got a very small femoral head and small acetabulum, usually 44, 46. And then you have to use 22 or 28 millimeter of head and they will dislocate. So this is a very good approach for a very obese patients. Only problem with defect in the posterior rim, it becomes so difficult. You have a good exposure, posterior soft tissue is preserved, less chance of dislocation, which I told you. Heterotrophic, how to avoid heterotrophic? So, gentle handling. Don't tease the muscles, please. One good shot of either a knife or cautery. Don't split the muscle too much. Or don't tease the muscle, not split. Don't tease the muscle. Lavage, very important. You do a 3-liter lavage, then chances of ectopic ossification are less. And if you are worried, give indomethacin for these patients. Avoid pericapsular muscle settling with narrow element, which is that is the reason lavage will be helpful. Now we'll go to anterolateral is finished. Anybody I want to ask anything on anterolateral?
Yes, anybody who have doubt regarding anterior and anterolateral approach, please ask question. Please proceed. Anybody?
I think most of the people are sleeping.
No, sir. They are listening. They are listening, sir.
No, sir, we are listening.
No, sir.
Okay, we go ahead.
Yeah, proceed, sir. Proceed. Please proceed.
Trans-trochanteric approach, which was popularized by John Charnley because he did all his right from 1968-69, he did all trans-trochanteric approach for a total hip replacement. Yeah. Because he felt, which I don't know whether I had taken the biomechanics lecture or no, but still I will tell you why he did it. He did a wide trochanteric approach because he wanted a good exposure, because he had a very good, fantastic exposure of acetabulum and the femoral canal was in front of him, and that's the reason he decided. Number two, what he thought biomechanically is he'll be able to lateralize the trochanter so as to increase the abductor liver arm. So it will reduce the work on the acetabulum, that is a polywear will be less. So he little medialize the acetabulum and lateralize the abductor liver arm. So he wanted to equalize between the body liver arm and abductor liver arm. And that is the reason he did a trochanteric approach, extensively trochanteric approach. But today we have implants of modularity and we are able to do what Chandler thought of with the trans-trochanteric approach. So today we do not use this approach unless we are in difficult condition, which will come to it. When do you indicate a trans-trochanteric approach? So it gives a fantastic exposure, consistent component, because you are able to see everything in the front, 360 degrees. Better cementing, because once you see properly all areas, it is possible to do a good cementing because there's no blind procedure. It's an open procedure. Adjustment of the abductor liver arm, which I told you, and you increase the stability so as to reduce the rate of dislocation. You tighten the hip whatever the way you want, because you can change the abductor anteriorly, you can put it behind, you can do distalize whatever you want. So this is one good thing happened with the trans-trochanteric approach. Indications are for revision, very difficult ankylosis, exposures. When we are not able to see acetabulum well, we are not able to open the acetabulum and put a 360 degrees of retractor. I think best is to detach the trochanter. You are in the front, behind, inferior, superior. So you will be able to do justice. Whenever there are major deficiencies in the acetabulum, you want to reconstruct the columns, you can do this. And dysplastic hips also, it is possible to do this trans-trochanteric approach. So as to reduction is possible also in dysplastic. The technique, You can do what is called intracapsular, you can do extracapsular, you can do bipolar, or it is called as a chevron. This was described by Woblesky, chevron osteotomy. So we put we put a Steinman pin and we cut like this. The thing will be like this. Trochanter is like this. It's called chevron osteotomy, which is same osteotomy which you have seen in the foot. It's a very stable osteotomy, so it doesn't slide. So that is possible. So intracapsular, this is the capsule, and that's your this. So we are right inside the capsule. Capsular attachment of the trochanter is preserved. This capsule is preserved here. It increases the static stability of the hip. That's why it is better. Non-Indian rate, but non-Indian rate is higher because it's intracapsular. That is the reason people are not in the favor of doing this. So extracapsular, sacrifice the capsule. Trochanter is freely advanced, proximal, distal, wherever you want. Better union rate than the intracapsular. So I normally do is the extracapsular. We detach the capsule also and lift the whole trochanter up so that you are able to expose in the front and superiorly. So best is to do an extracapsular. Reason is you can mobilize the trochanter well. Even distalization also becomes easier because you are release the capsule. You can move the trochanter wherever you want and better union rate. The wiring technique, a lot of wiring technique came into the picture. So it is a 2-wire, 3-wire, 4-wire, different types of knot, tension device, various instrumentation were devised for tightening this wire. A lot of new wires came. This is known as a spring-loaded. This was spring-loaded wires that was devised by Woblesky, and they were now recently also these spring wires are used. So most important fixation is a bipolar fixation. One, we pass the wire from the trochanter, from the vastus lateralis ridge. That comes from that will go underneath the abductor and come above and loop it here. And this is called vertical wire of Chanley. Second wire is passed is a horizontal wire. It goes horizontal around the neck, then comes in the trochanter from the two holes of the trochanter and gets attached here. And that is called transverse wire. So it is called vertical wire, which does not allow the trochanter to move up and down. And the transverse wire does not allow the move into anterior-posterior direction. So superior inferior migration is locked, and then anterior posterior is locked. So that's the way you get a bipolar stability of the trochanter. And the union rate has been reported to almost 98% with a good technique. Initially, Chanley had a lot of non-union because he was using a thinner wire, and they were not good wire quality of the wires as well as the tension device. So he devised actually a tightener, a Chanley wire tightener. Some of the old examiner might put it on the table. What is this wire? What is this? So you might have to know what is Chanley's wire tightener. So with this 2-wire technique, the rate has gone up, non-linear. So Woblesky devised a spring-loaded, and he added a third wire, and third wire coming from the bone in the medial side, and the third wire, and that had increased the rate of union to almost 98 to 99%. Suppose this non-union occurs, don't get worried. If the separation is less than 15 millimeter between the two pieces, usually the abductor power remains to 90%, 95% plus. Unless the trochanter is migrated haywire, gone into the axilla, then they are good. They are not good. So trochanter non-union, you should not worry. They will have a mild lurch, but less than 15 millimeter, they are compatible. So this is the wire. This is done 20 years, 30 years back, 1977. Kitna saal ho gaya, Shrikunj bhai? Anyhow, so
Yes, sir.
yeah, this is the wire which I am talking. This wire is the first knot is here. This wire goes from the canal, comes out, comes on the top of the trochanter, again loops here. And there is a special tightener which is allowed to tighten it here. and this is called vertical wire. The second wire around the neck at the level of the lesser trochanter or calcar, wherever it is feasible, goes around the medial side, goes behind and front, then through the trochanter, part of the trochanter, anterior part of the trochanter, posterior part of the trochanter. It comes out and then he has a knot. So this patient, the double technique will have 2 knots, and 3-wire techniques will have a 3rd knot. So this is done by my chief many years back. See how important. He had brought it down. Now the abductor liver has increased quite a lot. And that time we used to medialize the acetabulum. You see the medialization of the acetabulum, which we never do it now today. So that's the way. And look at the cementing at that time. It is only digital cementing. Srikunj Bhai, we did not have a gun. We did not have anything. We didn't have a pulsatile lavage. We didn't have a hypothesia, anesthesia. But this is because everything was in the front. Everything was in the front. So non-Indian has been reported very high, but these are wrong figures. Okay. So this is one of our own patient. Look at this. This is a trochanter. Wires are broken, and that's a non-Indian. This is 35 years. He is now hitting because he has got a wear. Now he is waiting for a revision now. This gentleman is a pharmaceutical man, and now he requires revision on both the side. The stems are still intact, channelless stems, and look at this, both side non-Indian, but the in-between gap is only less than 15 millimeter, and that's why he is able to carry out for 35 years. So the complication of trochanter osteotomy, non-Indian you should write, wire fractures, infection slightly more because you take another half an hour for this surgery. Exposure is too much, and that's why any surgery going beyond 1.5 hours is going to be a little problematic. 1 minute, Srikunj Bhai.
Yes, sir. Take your time, sir.
Ectopic ossification is much more compared to posterior approach, much more, because you are too much of exposure, too much of capsular, too much of muscle, whole muscle abductor is lifted. So you know that, and if you test the abductor, you have a little ectopic ossification. One, keep in the mind all the time. Blood loss is much more. If your posterior approach requires no blood loss, probably patient will require 1 or 2 units of blood for the transtrochanteric approach. These are one of the complications of the trochanteric osteotomy. Non-Indians are very common with obesity, technical difficulties, rheumatoid patients. So how do we tackle the non-Indians? Sometimes if the is too much migrated up, and it is only 15 millimeter, 10-15 millimeter, we normally don't do it. If it is migrated too much, or patient has got an abductor limb, you can revise this by reattaching some various ways we can do it. But again, the success rate is not that great. This is one of the technique of a hook device has been used for a non-Indian. And you can also put some grafts there. But unfortunately, the graft does not take place because there is usually cement there. Now we'll go to the next part of the exposure was extended proximal trochanteric osteotomy or extended trochanteric osteotomy. There are 2 different osteotomies. Extended proximal is almost 10 to 15 centimeter, which Wagner described. Hence Wagner, who described, which is called, he used to call transfemoral approach. American people have changed the name and they have now putting as on their own credit or extended proximal femoral osteotomy. But all of you should remember this gentleman is Wagner who described this osteotomy. He is known as a transfemoral osteotomy. It's almost like a same, but the people have little modification here and there, and now they have put it as an extended proximal femoral osteotomy. And second is extended trochanteric osteotomy, which is normal trochanteric osteotomy you saw at the base of the trochanter. Now This extended, we go about 3-4 centimeter down, which I'll show you, and then you do it. This is again for removing a very difficult stem or for exposure, because you have a large piece, the union rate will be good. Removal of well fixed, or sometimes you have to do a cement in cement. Removal of well ingrown cement or well cemented also. This is the osteotomy we use it. So I had told you transtrochanteric. This is number one as the base of the trochanter, and this is extended trochanteric. You just go 3-4 centimeter down. You take a larger piece, and the third is transfemoral approach, or you call it as extended trochanteric. That's the third. You can go 10 centimeter, 15 centimeter, 20 centimeter, wherever you want. So this is the way the approach is. And this gives unrestricted exposure. So distal extent of extended trochanteric after 3 to 10 centimeter distal to lateralalis, while the distal extent of extended go to any centimeter I told you. So from the tip of the trochanter, wherever up to the stem is ingrown, that amount you can take it. Osteotomy can be done posterolateral or anterolateral approach, fixed with usually cables. And if you are worried, you can use some stud graft on the medial side, but normally you don't require. Limb length can be adjusted because the soft tissue release every day. It has an excellent result. Transtrochanteric, extended trochanteric osteotomy or transfemoral approach is an excellent approach, and it is a very easy, and you can do a great job in the revision cases. When there is a well-fixed implant or well-cemented hip, you are not able to take out. Cement is not possible to take it out with an endofemoral approach. Endofemoral approach is you watch through the canal. Here, you open like a book, which I'm going to show you. You open like a book, and you will be able to see both the pages of the book on this side and this side, both the side, and then you can take out all the cement possible. So this is the indication, well fixed, either cemented or porous implant. Wherever there's a lot of lysis, trochanter overhang, sometimes there's a varus remodeling. You will not be able to enter inside. There's a maliliated proximal fragment. You won't be able to enter into the canal, and these are true indications. So well fixed implant, both cemented and uncemented, trochanteric lysis, trochanteric overhang or varus remodeling, and malalignment of the proximal component area. This is an excellent approach. A lot of surgeons get worried, but this is the time does not take much time, and actually you do not have to struggle. So you will be reducing your operating time if you do this transfemoral. Once you start struggling taking out cement from inside, and after 2 hours you feel that you can't take it out, then you do transfemoral. Is not good. You should plan right within 10 minutes of your surgery. So how do you do it? The Wagner described slightly different, and this Americans have described slightly different. So Wagner, what he did a right from the vastus lateralis here, right from just in front of the linea aspera, going right of the medial side. So he lifted this flap completely on the medial side, keeping the medial hinge intact, keeping the whole medial hinge intact. And these, the American describe is from anterior posterior. So same vastus lateral is kept intact, and you keeping the medial structure intact here. So in the Wagner went also on the medial side. So excellent exposure of the femur and acetabulum, because you are almost looking like a transtrochanteric also. So acetabulum is also very clear, because the abductor goes in the abductor will go in the front completely. So you will have wide exposure of acetabulum and complete exposure of the femur, because you open the book. It's a fairly atraumatic. Decrease perforation rate and fracture, because you are seeing everything in the front. You do a correction of deformities, protection of compromised trochanter. You will compromise, because otherwise the trochanter will get fractured. Whenever there is osteolysis, you try to put a retractor, it will fracture. So that is very important. And predictable healing. I yet to see a non-Indian. I must have done about 60 to 70. I have my own publication also with this transfemoral approach in IGO with a long-term result. But I only see one patient of delayed union that united after about 8 or 9 months. But the healing is good. Reason is the osteotomy is very wide, very wide. So there will be some part of the healing will take place and it will be all right. And you are keeping the vascular structure and the muscle belly intact. It is a very important that you don't dissect muscle. Vastus lateralis has to be kept intact. And I have a video, but I will not be able to show you today. So you look at this. That's the abductor. That's the vastus lateralis, and the whole flap, whole tissue is intact. So how this is going to heal? Because all soft tissues are kept intact. And you have opened the canal and you will see the whole femur in the front, and you will see the acetabulum 360 degrees. So exposure of the femur and acetabulum is perfect. So you are not going to do any mistake of perforation or malalignment of the components. And you can lengthen this patient very well, whatever, even is short by 4 centimeter, 5 centimeter, because all the soft tissues are released. So how we do it? With this approach, posterior approach or lateral approach. See, this is the vastus lateralis. That is your abductor. This is the linea aspera here. So we are making the multiple drill hole here and then a transverse here or oblique here. So look at that. So you can see the implant there, and then you put some couple of wires here. So this is one such patient of ours. This is a taper break. This is a taper has broken, and this is a well cemented. This is impossible to take it out. So we did a transfemoral, open this, there's just 2 wires, and look at the healing. How beautifully healed up. So that's the transfemoral approach. Anybody wants to ask anything on transfemoral approach? Sugunj bhai.
No, sir. Everything is clear for me. Anybody else wants to ask a question? Anybody?
Okay.
Yes, sir. Proceed, sir.
We'll go further.
Yes, sir. You can proceed, sir. Are you comfortable, sir? Are you comfortable?
I'm okay.
Okay, sir. Okay. Then you can proceed, sir.
Posterior lateral approach. First actually described by Gibson. A lot of modification took place by many people. Horwitz, Marseille, Fletcher, so many modification took place. Some people said southern approach, some said somebody other approach. But actually, basically, it is a Gibson's approach, to be frank. So everybody should keep in mind this is a really Gibson approach with modification. Why is common to utilize? Reason is high success rate, easy dissection, relative atraumatic soft tissue exposure. Relative, not all, because I told you already, markers are very high because you are cutting piriformis, you are cutting rotators. Only you are keeping the abductor. That's why a lot of people feel that soft tissue is less damage. Relative atraumatic soft tissue, wide exposure. One important thing, agreed totally. You can extensile, you can go proximally, distally. You can do extensile approach with this. Ability to reconstruct posteriorly. Soft tissue as well as bony structure. And that's why a lot of people prefer this approach. Why attracts? A lot of people have attracted, especially Indian people. A lot of people have attracted. Decreases the time of surgery, very quick surgery, excellent exposure, minimum blood loss, minimal muscle damage, reduction in ectopic. This is one important factor. Very much, the posterior approach has got less ectopic ossification compared to anterolateral and transtrochanteric. Fast rehabilitation because you are keeping the abductor intact. Gluteus medius is the master muscle intact. So we normally do with a lateral posterior approach in lateral position. There are 2 important. The position is very important at the posterior approach because your pelvis has to be sandwiched between sacrum and pubis. Sandwich, Shikunj, very important. It should not move. As much as stable, it is important. And also look at the lumbar lordosis of the patient also at that time, or kyphosis, because your position of the cup is going to be different. And second important thing, you can use a sandbag on both the side of the chest and as well as back, and put a strap here. This also is important because we have to see the torso. Very important, the torso has to be right in the center like this. It should not be like this, it should not be like this. Because your alignment guide are related to torso, which I am going to show you. Torso. So torso has to be right in the center and straight. It should not fall in the front, it should not fall in the back. We used to use same type of support on the chest and back. Our anesthetists are not allowing us because he says a lot of chest compression takes place. So I have stopped using that. I am now using only a sandbag and a pillow. Very important. Another important thing, you see a pillow here. Another important thing, this hand has to be protected with the ulnar nerve here. All of you must keep in mind, it should not hit a sandbag here. Otherwise, they will wake up on the same side. They will next or third day, they will tell you, sir, ye ungli mein झुंझुनाट हो रहा है. So this is very common, ulnar nerve praxia, ulnar nerve, because of the constant pressure here. So I am very careful. I put a soft pad here, and I always tell my anesthetist, be careful there. So positioning is important. So sacral post and pubic post, and these are radiolucent. So if you want to get image inside, it is possible to see. And these are the all gadgetry, how you can press this. These are Mackay attachments. Incision, 3 fingers anterior to posterior superior iliac spine. That was originally described. We don't do this long now. I'll show you. And progress to greater trochanter, and second limb extend along the shaft 10 to 15 centimeter. That's the original description. Now, today, we are 4 or 5 centimeter in the trochanter side and 4 or 5 centimeter below. So we are now only 10 centimeter of incision most of the time. Maximum is about 12 centimeter. Today, incision becomes smaller and smaller, and now we are moving to MIS also. Even with 5 centimeter incision, you can do it. When I was young, I used to do it, but now I don't do it. So that's the approach. You have seen the posterior spine. That's a trochanter. There's a curved limb, and this is on the shaft. Now today we will have this much incision. We don't go below the trochanter now much now. So once you've done that, you get the TFL. And there is always pad of fat, which I told you. This pad of fat signifies that there is a sciatic nerve behind. You don't dissect this pad of fat. You don't excise the pad of fat. And then you will see, once you have taken this, you will just straightway see you will see the bursa of the trochanter. Release the bursa. You will just see the all the external rotational in the front. You don't have to do any exposure difficulty. So it's all exposed right in the front. So if you look at the anatomy here, gluteus is cut here. That's the gluteus medius here, and you see this is a piriformis coming in, and piriformis is a white shining tendon you cannot miss. And just superior gemella, inferior gemella. Below that will be quadratus. There are two nerves, which is superior gluteal nerve, which is right there, which is very far away. There is no question of damaging here. And if you see here, there's a gluteus minimus is underneath. Here also, you don't have to release the gluteus minimus unless the hip is difficult exposure. So we just detach the piriformis and gemella. Even sometimes you can keep the quadratus here, and there is a small vessel coming between the gemella, inferior gemella, and quadratus. That you might have to cauterize, and there is a small vessel coming on the tendon of the gluteus, tendon of the piriformis, that is called nascent vessel. This is a nascent vessel here. This is a very, very small vessel which you can like it. Most important is only one bleeding vessel which is just between the quadratus and the gemella. That's the only one vessel which is here. There is no other vessel which will come there. So we don't have to worry much. We don't have to worry much. So then you rotate the hip to 90 degrees, internal rotation, release this. If you require, if there's difficulty, you can release the anterior capsule, you can release the psoas. So it's a very, very wide exposure, we can do wide exposure. So you can literally go to the anterior capsule with this approach. Then we measure the offset, place the trial component, and then you cut I'm going to show you a short movie, then you will realize what exactly where angle cutting and everything I'll show you. The 6-7 minute movie which will give you everything. So that's your neck cut, you put a retractor, protect the anterior capsule here, protect the anterior capsule here, protect the hip abductor here. So this is very important before cutting. Otherwise you will try to go inside the abductor, or anterior capsule should not be cut, because once you cut the anterior capsule, your neurovascular is just very close. Be careful. Very important. Sometimes you are not able to dislocate with flexion, adduction, internal rotation. This is called FADR. Why? There is a vacuum in the acetabulum sometimes, which is not allowing. Sometimes persistent posterior and superior, still you are not releasing the capsule well. So once you are not able to dislocate, don't try to push. You will get a fracture of the shaft. And if Srikunj is assisting, you are like 100% because he has got a good muscular man. So
Yes.
you have to be careful. So gentle handling, hip should dislocate. No takat required. If you require takat, that means there is some soft tissue contact. Somewhere you are not released. So revisit. This is very important. Up till now, my experience, I had only 2 patients on the table. I had a fracture due to my mistakes. Only 2 patients up till now for last 30-35 years. So persistent posterior and superior capsule attachment. If any surgeon says he didn't have a complication, he is either lying or he has not done enough work. Every surgeon has the complication. Srikunj bhai, keep in mind.
Yes, sir.
Intact labrum, which is not allowing. Protrusio, definitely it won't allow you. Coxa magna, very large head. Residual ligamentum teres, very strong, sometimes strong ligamentum teres may not allow. So these are the things you have to keep in mind. And if you can't dislocate, don't be heroic surgeon. Do a neck osteotomy, take a sandwich or napkin ring, which I told you, and then take out the head in piecemeal, especially in grade 2 and grade 3 protrusio. Do not do any heroic movement. Then putting retractors are very important. See, this is the acetabulum. This is 12 o'clock. This is 6 o'clock. This is 3 o'clock. This is 9 o'clock. So this is transverse acetabular ligament. So your front retractor has to be here. If you put here, you will get into neurovascular. Look at this model. If you put here, neurovascular is here. And if you put it here, the neurovascular is far behind. And this is the thickest portion of the ilium, and you will not get fracture of the anterior column and anterior lip, in spite of a good assistant retractor man. So this anatomy is important for you. So your one retractor goes here between the 12 o'clock and 3 o'clock, one retractor inferiorly below the transverse, and one retractor in the ischial tuberosity and below the 9 o'clock. It is around 7 o'clock position. You put a ischial pin or a ischial retractor. Very rarely you require superior. If you cut nice superior capsule, you don't require superior retractor or a Steinman pin or a Chanley pin. So this figure gives an idea how neurovascular structure is protected. So important for all of you, for the posterior approach. So you have seen these retractors. There's a ischial, there's inferior, there's anterior, superior Chanley pin. 360-degree exposure of acetabulum. Then you put a
Sir,
Ah,
sir, due to your net connectivity, some disturbance is there. Sir, can I stop your video and you will be able to continue with your screen?
okay, no problem.
Just I'm stopping your video so that your net would be less consumed.
Okay.
Yes, sir. You can proceed, sir.
Good. So you start rimming this with a proper angle, which I'm going to show you. And this is the way we do this. That's why important is torso. So torso has to be straight, which I told you. Another important thing is with the anteversion. So with some degree of that's why we must know where is the torso. Sometimes if the TAL is not available or revision situation, we have to just identify where is the torso and you get onto 15-20 degrees of anteversion. That is the importance of the torso and importance of anteversion. And this 360-degree exposure will help you. So you need to put a proper anterior retractor. If you don't put anterior retractor properly, you will not be able to get your reamer into anteversion. And that's why many people fail to give anteversion to the cup. And that's the way 40 degrees of angle and 15 degrees of 15-20 degrees of anteversion. So this is called the opening angle or abduction angle. That is called anteversion angle. So you have to get 40 to 40 degrees of opening angle or abduction angle or 15 to 20 degrees of anteversion angle. That's the way we rim. And that's why we have to put the cup into the safe zone. This was described way back. This is called lavinic zone. Lavinic zone. You might require, some people may ask you a short note on a lavinic zone. So lavinic zone is nothing but the safe zone of acetabulum. This was described very long back in 1970s. So what is this? So if you look at this, this is the abduction angle on this side and this is the anteversion angle on this side. So I told you 15 degrees was the normal anteversion angle at that time was given. We give a slightly more today. We give around 20 to 25 degrees. And abduction angle is 40. So this is the, if you draw a line from 40 degrees right in the center, 15 degrees right in the center. If you get this, it is a very called as a safe zone. Safe zone. So all your cups should be in the safe zone. Maybe 5-10 degrees on the either side, but you should not go above 50 degrees of abduction angle. If you go above 50 degrees, it is called vertical cup and hip will dislocate. Hip will dislocate. Anteversion maximum is 25 degrees at that time described, but today we do it actually at 25 degrees. And why again torso is important? Look at the torso here, because we are going to align one arm of the arm of the cup holder here, and second arm is here, anteversion angle arm. So my is going to be like this and going to be 20, 25, 30 degrees like this. There are two arms. Look at this. This is one arm coming on the torso. Second arm is known as the anteversion arm. Anteversion arm. And look at this. This is known as a vertical arm. If I put this vertical arm, it is 45 degrees. If I turn this vertical arm towards the surgeon, towards the patient's leg, it becomes 40 degrees. So we want this arm not perpendicular to the ground or to the table. We want 5 to 10 degrees on this side, and anteversion, this is on the torso, and this is the anteversion angle of 15 to 20 degrees. So this is the importance of keeping torso properly so that you are able to use acetabular guide. We are going to have a varieties of anatomical landmark, but this is one of them. This is one of them. We are going to use a transverse femoral ligament. We are going to use a posterior lift. We are going to use anterior lift. We are going to use a posterior lateral corner. So many factors we are going to use. This is one of them, which surgeon gets the additional advantage of using the jig. The femoral canal should be opened right into the piriformis fossa. If you open on the medial side, you will go into varus. If you open too much, you will go out. So very important to open the piriformis fossa area is a sclerotic bone there because it is attachment of the piriform is a very, very strong tendon. So you will always see a sclerotic bone there, and that is nothing but the piriformis area. So you have to open that nicely and enter into the canal in a right direction. Then you will have to lateralize your remers, because if you go on the medial, it will go into varus. So you have to take out a little bit of bone from this side so that the entry becomes much more. Look at this. This is the bone which is taken out. Then only you will be able to enter. And that's you have to use a curate to take out a little bone from that side. If you don't do it, look at this surgeon. The femur, this has gone out. The whole femur is out. So this is perforation, very easy to do it. What the limitations are here? Every approach has its limitation, advantage, disadvantage. These are some of the problems are inability to assess the exact position of the pelvis, because pelvis moves with this approach. In supine, Stikunjbai, pelvis does not move, it is on the flat.
Yes, sir.
Here, whatever the amount of sandwich you do, still, if you put an anterior retractor, the whole pelvis gets retroverted.
Yes,
If
sir.
you put, if the surgeon assistant pulls behind retractor too much, you will have again a problem of anteversion.
Yes, sir.
The whole thing is moves. So it is not a static structure. So very important, inability to assess the exact position of the pelvis. So malposition of vestibular component is much common in posterior approach than the anterior approach. Crystal clear?
Yes, sir.
Nerve injury, because nerve is very, very close. You have to be very careful. Increased incidence of posterior dislocation. This is the highest problem. Every student must know, examiner will going to ask you. The highest rate of dislocation is always with the posterior approach, because you are not able to repair the posterior structures. As you flex the hip, internal rotate, which is a common thing happen, hip dislocates posteriorly. So this is the reason many people are going away from the posterior approach. But something has come to rescue our surgeons in India, that we have got now large heads available. So we have got now 32 and 36 head available. So our dislocation rate in the country has gone down in spite of posterior approach. Is it clear to all of you?
Yes, sir.
Yes, sir.
Yes, sir.
So the here again, the medial circumflex artery, which I told you, which is easy to ligate, that there is nothing to worry about it. Exposure anterior column not possible with this approach. Poor and canal exposure. If you do trochanteric osteotomy, canal is in the front. Here there is chances of varus placement with the posterior approach. If you don't open the canal laterally or don't use a proper instrumentation, so there is a chances, there is a possibility. Poor exposure of internal canal of the distal femur. And dislocation, other contributing factors are, it's not only approach, previous surgeries, surgical approach, fault tip component position, osteophyte impingement of the cup to the neck, trochanter non-union, abductor weakness, so many other factors are there, which we are not going to discuss. How do you reduce the incidence of dislocation? Careful repair of posterior capsule, which I am going to show you. And complete external rotator has to be sutured back with a double bracing phenomena like strict protocol, tight soft tissue structure closure, and proper alignment of the component is very important, which is not, I have missed it here writing. Okay, so most important is alignment of the component. Second, offset, proper offset. Third, soft tissue tension, capsular repair, and protocol. These are 5-6 things you have to keep in mind to reduce the dislocation with the posterior approach. If you are going to be posterior surgeon, you got to keep all this in mind and use a larger head. So this is very old literature. Don't quote this literature. Posterior lateral approach 5.8, anterolateral is 2.3, revision 20%. So these are very, very old figure. They are in 1970s and 80s. I will show you the recent figures also. So why? There is a confusion in the literature. Reported is from 0.3 to 9.2. Who are these 0.3 and who are these 9.2? We don't know, because we are putting everything in the single basket. Parkinson patient also, cerebral palsy patient also, 90-year man also, we are putting everything in one single basket. So you can't do it. You cannot compare that. You are also different approaches. All that is a very confusing literature. That's why we really don't know what is the reality. So reality comes now is today with a posterior approach less than 1%. If you look, if you follow the principle which I just told you, I am repeating again, not posterior approach, but not extensive, soft tissue dissection proper, posterior structure has to be released properly and suture it back, proper offset, proper alignment of the component, transverse acetabular ligament 10 times underline, you people underline, alignment of the acetabulum according to the transverse acetabular ligament, increase the offset, increase the head size, posterior capsule repair, and you will bring less than 1%. All recent reports are excellent with the posterior approach, but all the principle has to be kept in mind. This is the way the capsule is repaired. Osseous sutures, osseous sutures. This is a video, watch carefully all of you. Every important step which I have described, it is in this. I might Sukunj bhai, how to take out this laser out?
Yes, sir. Laser pointer, first one.
Take it out. Okay. Thank you.
Yes, sir.
This is
Yes,
the
sir. Video is playing. Yes, sir.
uncemented. That is the transcervical fracture. We do the templating of the acetabulum. Has to be know what is the templating. We'll do the femur templating. We'll find out the limb length. That is a 3 millimeter short patient is. That's the piriformis tendon. Can you see the structure here? That is a stay suture. This is a very glistening important structure. Now I'm releasing the capsule and then making the condylar mark, how much lengthening I have to do. And that is a gradual flexion, adduction, internal rotation, and taking out delivering the head out of the acetabulum. Once I had taken out, I put a drill here, and I will measure the vertical offset. I will measure the horizontal offset and put it on the blackboard so that I know what it is. Now that is the marking at 45 degrees cut. That's the neck cut. I do the sclerotic bone, piriformis fossa. Oh, nothing medially. Look at that. It is all released perforation on the lateral side, and that's the reaming most lateral. This is called lateralizer reamer. So you take out the lateral bone and then you broach and look at the anteversion. That is tibia and that's the femur. How do I go backward? Okay.
So, select in video. Just select in video. If they are showing duration.
Here, anyhow, that is my acetabulum reamer. That's my cal here. So that is the way anteversion. That's anteversion reaming 15 to 20 degrees. Gradual sequential release. Look at the quality of bone coming, cancellous bone, and that's a trial cup without touching, and that's a real cup going inside. These are the extra osteophyte posteriorly, anteriorly. That has to be taken out. Otherwise, this is the alignment. You see now, we will be seeing now. That is vertical arm. That is torso arm. That is your anteversion rod. Now you will see from the side. Look at that. It is not perpendicular. It is inclined, and that is your trial reduction going inside. Combined anteversion of Jranavat. 45 degrees of anteversion. 25 degrees of internal rotation. I will see this here. Look at this is the capsule and rotator. It's going back. Look at the intraosseous. These are intraosseous sutures, osseous sutures. All 3 or 4 sutures are packed up. I normally suture the abductor bursa also. This is, look at this bursa. I suture this bursa also. Look at the whole bursa is sutured. So that's your post-op X-ray. That's the way the things are. Just now, a few more slides. Minimal invasive surgery evaluation was now in after 90s. We started using the minimal, and the credit goes to Thomas Skulko from Special Surgery Hospital. I was fortunate to see his surgery way back, and I was practicing actually with this mini approach during my Bombay, during when I was in Mumbai. But today I have stopped using because it is not possible for the teaching purpose. That's the reason I now extend my approach slightly more, but I don't do too much maximum invasive. But now I want to expose the such a way that I am able to show on all my assistant the structures. Number one, I am able to align my component, and I am able to see everything what I'm doing. That is should be the exposure, which I will tell you what is the Dr. Ranawat's statement. So typical provides good exposure, whether it is maximum or minimum, neurovascular protection, and confident of implant placement. I told you. So what Ranawat said, with this incision, I can do every hip, whether it is a difficult or normal hip. I can expose it, I can see it, I can teach it. This is what I'm following for last more than 15 years. I'm following this. And that's the reason my exposure is now 10 centimeter or maybe 15 centimeter. I never do now 7 centimeter incision. Minimal invasive requires training, special instruments, well-trained assistant, proper patient selection is very important. You can't do every patient. And that is the only reason I went to see the master surgeon, and I really got the instrumentation also back in the country at that time. So you can't do this for this lady. So cannot do it, obeys weak bones, protrusive deficiencies, heavy muscle, very muscular man. You can't use this approach. Wherever there are implants already, posterior acetabulum implants are there. How can you use a mini approach? It's just not possible. So it is a very straightforward avian or primary OA hip, you can do it. But not all other patients, you can't do it. And also, not for every surgeon. A surgeon who has less than 50 per year volume, you should not go into this. You should, because it's got a double complication rate. So surgeon who is doing almost every day 1 or 2 hips should do it, not other surgeons. A lot of people then, after a single incision for mini, the second era came about 15 years back. Richard Berger was the surgeon who popularized the 2 incisions. Touch wood, India, it never picked up, and we are all you people are lucky that India never faced a 2 incision as a totally replacement. Nobody did it. Acetabular preparation through anterior incision and femur through posterior incision. I'm going to show you a couple of slides which I got it from my colleague from Singapore. First is anterior incision. You read IITV to know the exact incision and as well as the acetabulum. Second, also posterior incision. You need IITV to see you are entering into the canal or not, and what is the dimensions are. So this is the anterior incision, and this is the anterior incision which we described at that time. That is your acetabulum. That's the head extraction. That is the only what is the size of the head? That is the only incision you require. And this is from my friend Dr. Low from Singapore General Hospital. I'm thankful to him. I'm just quoting his name also. And this is the image intensifier you require for the acetabulum, and that's your anterior incision. This is through this incision we put a femur, and then inside you join and then reduce. Inside you have to join the both incision inside. Then only you will be able to reduce the hip. So that is your image intensifier. This is your posterior trochanteric incision. That only whatever the broach is, that is the only size you use. Here you split the abductors, and again your damage takes place. CM picture shows the degree of fit and canal. You are for uncemented, so accordingly you use it. So the lot of complication went with this approach. So everybody in the world has left this. If any examiner asks, do you know posterior two incision, you just mention it. So due to the rate of complication, malalignment, fractures, so many complications occur. You can't measure anything. You cannot limb length. You can't do it. You cannot measure offset. So many things you can't do it, and that's why people have left that. And Richard Berger was the originator. So you must, if you want to remember and get a gold medal, his name you can quote his name. So still, one may lead up. I told you just now, surgeon, if he says no complication, two things. Either he has not done enough work or he is lying. So everybody has his own complication. One may land up in complication, wound healing, periprosthetic fracture, malmagnetic component. This, look at that. Sometimes this happens. The whole horse has gone up. So each thing is hard. Sometimes you have to hide it. Sometimes you have to hide. It all takes longer than you think I will. But everything you do it, move on, and one step at a time and slowly, and you will progress. That is the way. I thank you for patience hearing.
Thank you so much, sir. Thank you.
Thank you, sir.
Thank you, sir, for so much extensive and good lecture. It was absolutely every detail was given.
Okay.
Thank you very much, sir. Thank you for your time and thank you for your effort, sir.
Bye, Shigil. Bye.
Thank you very much, sir.
And sir, Ganjwala sir's confirmation has come for another lecture of cerebral palsy.
Yes, good.
So
When?
we'll arrange on Monday or Tuesday.
Okay. And tomorrow?
Tomorrow, sir, I'm going to be in contact with Monil, sir, and we'll sort out the issue. And once